real life.
Okay. So, good evening, postgraduates, and welcome to this 58th episode of All India Postgraduate Teaching Program, which is an initiative from ARC AIOS. We call this PG program a bit different program compared to other postgraduate teaching programs because we cover the uncovered aspects of other teaching programs like case presentations. We also have journal clubs. We also have presentations on OSCE, and rarely do we have didactics on topics which are not comprehensively available to you in textbook. In this 58th episode, we are going to have a didactic lecture on ocular changes in pregnancy-induced hypertension, which had been a long question in one of the MS finals. And this didactic lecture would be presented by Dr. R. Rajesh, who is a senior consultant, vitreoretinal consultant, and in the Department of Vitreoretina and Ocular Oncology at Sankara Eye Hospital, Bangalore. My special thanks goes to Dr. Preetham Samant, a dear friend of mine who is a retina consultant at PD Hinduja Hospital, Mumbai. Professor Dr. Malay Chaturvedi, who is a director of Akshi Eye Care Center, Kanpur, and who is also a president-elect of UP State of Ophthalmological Society. And he happens to be my co-colleague during my Shankar Nethralaya Fellowship days. And our own rising star from Nagpur, Dr. Rahul Tiwari, who is a director and a vitreoretinal surgeon at Shivam Nethralaya, Nagpur. I'm really thankful to all the three discussants for sparing their valuable time for the postgraduates. Now, without much ado, can I request Dr. Rajesh to share his screen, and let's move ahead with the initial part.
Thank you, sir. Hope my screen is seen and I'm audible.
Yes, Rajesh.
Thank you, sir. I thank Prashant sir and AOS for this wonderful opportunity. Coming to the topic per se, I've been asked to speak about ocular manifestation of pregnancy-induced hypertension. So if you look into, there's nothing much of a difference as compared to whatever the graded hypertension or malignant hypertension takes place. When we look at the ocular manifestation assets in pregnancy, there are lots. And this is a very, very defined topic as far as PIH in ocular manifestation is concerned. Let me go through it, a few of added slides. And I would request the other moderators to help me out in fulfilling whatever I have not covered in this. So coming to PIH per se, what do we mean by pregnancy-induced hypertension? It's a very classical defined as it's a clinical syndrome which occurs if you look into the international data. It consists of 3 to 5% of all pregnancies. And as any other hypertensive associated problem it is a multisystemic disorder. And the clinical spectrum, it has a huge variation from just being an hypertension, which is detected exactly in the second trimester at around 20th week. And it goes on to have preeclampsia to eclampsia and HELLP syndrome associated with eclampsia. So that's very, the mortality in such situations are very, very high because of disseminated coagulation and other problems. So as far as hypertension on a whole in Indian scenario is concerned, so about 10% of all primigravidas or the first pregnancies do have some amount of hypertension, and 8% of multipara and other pregnancies can be associated with hypertension. Among these patients, if you look at the incidence of eclampsia is very, very high in developing countries like us, where it's approximately about 1 in 100 to 1 in 1700. As compared to developed countries, which is less than 1 in 2000 deliveries. So average incidence of PIH in India is approximately 15%. So every 15 women out of 100 who end up in the labor room will have hypertension, and we need to have a close look at what's happening, not only in the systemic parameters as well as in the ocular parameters also. So let's come into how do we define PIH. So if the systolic blood pressure is more than 140, and diastolic pressure is more than 90 on two separate occasions after 20th week of gestation, which is about 4 hours apart, comes into the preview of PIH. Or there is another definition which has been put forth where the systolic blood pressure is more than 160 and diastolic more than 110 in one reading also can be included as PIH. So other associated features along with hypertension being the proteinuria. So if there is more than 300 milligram of protein in 24 hours urine, or the protein creatinine ratio of more than 0.3 in a urine spot test, we do consider as PIH. Let's look into the other features which are a little bit less associated with, but can be definitely present. Thrombocytopenia when the platelet count is less than 1 lakh per ml. Impaired liver function test, twofold increase in the liver enzyme, which includes the SGPT and SGOT. Renal insufficiency if the serum creatinine is more than 11.1 milligram per deciliter. Pulmonary edema, which is quite rare but can be seen in these patients, which includes sudden onset of sob with creps in the lower part of the lungs, which can rise up to the mid part by the end of termination of pregnancy. Cerebral or visual symptoms, excruciating headaches, scotomas, and scintillatants, which I'll be covering in the later part of it. So whenever we talk about any pregnancy, there is a myriad of changes which can occur from top to bottom in a lady. So if at all we constrict ourselves to the I part of it, so we can divide it into two parts, the physiological changes and the pathological changes. Physiological changes, we expect it to occur in every person who undergoes this physiological change, that is pregnancy, in every lady. So what are the things that we are looking at? If you look at the intraocular pressure, the IOP is for that particular individual, it's less than the non-pregnant state. The lid may have chlolasma, that is the pigmentation which occurs about 5 to 70%. Sometimes it might be very, very dark and very characteristic. In conjunctiva is concerned, there might be subconjunctival hemorrhages on varied intervals or may not occur at all. Tear film, there is definitely alteration in the tear composition. As far as cornea is concerned, there might be decreased sensation, Krukenberg spindle, which includes vertical lines of pigmentation on the endothelium, increased thickness, which is basically due to more of edema, which accumulates into the stroma, alteration in the refractive error because of all of these changes, as well as even the thickness part of it. When we come into the lens, there is increased thickness, even again because of hydration. And because of this, resultant refractive changes can occur. As far as optic nerve is concerned, there might be a slight enlargement of the pituitary gland and some amount of visual function, visual field changes can occur. So these are physiological changes, and we know that once the pregnancy is terminated with an eventful outcome, so all of these changes get back to near normalcy. So let us look into the other aspect, that's the pathological changes. When what I mean by pathological, if they occur, they might leave some residual issues or residual functional losses because of these changes. So look into the orbit. So there might be growth of hemangioma, certain hormonal associated tumors can cause changes during pregnancy. One of them is hemangioma. They can cause growth of hemangioma both in the choroidal as well as orbital. There might be arising of carotid cavernous fistula, which can cause bruit, proptosis, enlargement of the, retropulsion of the growth of the eyeball. As far as lids is concerned, ptosis, Horner syndrome, facial nerve palsy, these are certain changes which can occur in lid. As far as conjunctiva is concerned, like any other chronic hypertensive changes, vasospasm and corkscrew of the blood vessels at the limbal endings can occur. As far as retina is concerned, you have worsening of diabetic retinopathy, which is one of the commonest. Other things includes the vascular changes in hypertension, which is pre-eclamptic and eclamptic. Serous central retinal detachment, serous chorioretinopathy, central serous chorioretinopathy. And the tumors, intraocular tumor, which includes the melanoma. There's a sudden spurt of growth of melanoma because of the vascular increase. The supply of the vascularity increases in these, during these periods, and that causes growth of the melanoma part of it. When we come into optic nerve, there is very high chances because of systemic alteration of hypertension and diabetes, which is commonly associated in our Indian condition with ischemic optic neuropathy or non-arteritic ischemic optic neuropathy. Both of them are common. Papilloedema, because of increase in, I will discuss that also in a bit more detail in the end chapters. And optic pathway, there might be cortical blindness because of, it might be due to pituitary apoplexy or any of the vascular compromise which can occur because of the hypertension per se. So let us deal with some of these and restrict ourselves to, again, the hypertensive associated changes in the ocular features. One of the commonest that we have, the physiological, which I have already enumerated in the list, is the subconjunctival hemorrhage. So it occurs in a small point at one of the areas, and then it might spread because the subconjunctival space is loose, and it might spread into one quadrant and or all the quadrants of the eyeball. So, and usually without further proceeding, bleeding, it recovers about a week to 2 weeks in time. It usually recovers. No need of any medications for this particular condition. So as far as retinal changes is concerned, I go in deep dig more into my subspecialty. My topic will not be completed without touching on to diabetic, though it is not the purview of this talk. So diabetic retinopathy is the commonest change or the progression which occurs in pregnancy, and there is a very quick progression both in gestational diabetes and non-gestational diabetes. The cause might be hematological alteration, hormonal, metabolic, or cardiovascular or immunological changes which can occur in pregnancy. The basic outcome of all of these changes is there is an increased retinal capillary blood flow, which leads to endothelial cell damage and thereby causing leakage and increased enhancement of the changes which occurs in a normal diabetic retinopathy associated issues. Progesterone elevates the production of VEGF. That's another factor which causes more of angiogenic, changes, though it is required. But in a patient who is already, labored with diabetic retinopathy changes, this can aggravate the problems. The severity of progression can also be associated with others, like when the patient, had started pregnancy. What was the degree of retinopathy at the onset of pregnancy? The time since the onset of diabetes, because we know that more than a decade or 2 decades, that 100% of the patients, despite of whatever appropriate control of diabetes, they might end up having some amount of retinopathy changes. If the control is not very good, then you can think about the changes that can occur. Especially in Indian women, who are almost about 40% of the pregnant ladies are associated with anemia. So the changes are even more exacerbated. The glycemic control and other allied systemic disorders, like, for example, other collagen vascular disease or hypertension or renal problems, can further aggravate the problems as far as diabetic retinopathy changes is concerned. So a typical case, you can see this I pulled out because there is one of a very close MBBS batchmate of mine, whose elder sister, who presented to us quite some years back. And this is what she presented with mixed retinopathy. And this was at the onset of the pregnancy, almost about in the first trimester. And by the end of about the second or the beginning of the third trimester, she already had developed hard exudates and central involving diabetic macular edema. We could safely do some amount of focal laser because we didn't want to advise any anti-VEGF. Anti-VEGF is still what we can say as put it into FDA group X as such, because we don't know what is the outcome of the profile or the side effects of anti-VEGF on fetuses are concerned. So we could safely do some amount of laser and preserve the vision to a certain extent till she terminated the pregnancy part of it. So coming to another more pathological problem, which we can see, it's a bit rare, but in a patient with malignant hypertension, or especially in patients who have preeclampsia and eclampsia, one of the commonest thing that can we see is the Elsching spots. It's contrary to whatever we see as the after cataract in the anterior segment. This is in the posterior segment. I'll just enumerate one of my patients. There's a medical history of blurry vision, she was in a 6th week of postpartum. Visual acuity, when we looked at it, it was 6/60. She had an RAPD. The arterial hypertension was somewhere hovering at around 190/120. She was on a single medication. Why was she left alone at this? We are yet to determine. So expecting that changes should have been there. And since ICG is quite relatively fine in doing in these postpartum or even during pregnancy also, so we went with the ICG angiography, and we could very well see these hypopigmented spots in the macula. You can see well-defined hypopigmented spots, which enumerate as capillary non-perfusion areas in the choroid, is called as Elsching spots. I could enumerate only in 2 patients as such during the entire almost about 18 years of practice. And this is one patient in which I could record it very well. So another change which can occur during pregnancy is retinal vein occlusion. So why they are relatively more incidence, or maybe just because of the hypertension per se, or any other features, I'm not sure at, but I think hypertension itself. So whatever they present with, again, acute onset of vision loss. This is a primi gravida. Just a second. So with PIH, which was diagnosed with PIH, and she presented at 32 weeks of gestation with a sudden onset of blurriness of vision. But when she presented to us, we noted that the left eye had a bit of media haze, and there was an impending CRU. It was not a full-blown CRVO, and the macula was not edematous still. So with this in condition, we thought, like, let us go ahead with got a consensus from the treating obstetrician and gynecologist, and we thought, like, we'll go ahead with the oral steroids because some of the patients do respond, especially in the younger age RVOs. They do respond to oral steroids. So we went ahead with it, but the impending CRVO went into a full-blown CRVO with a lot of cotton spots and macular edema 3 weeks later. So she was almost at the term of pregnancy. So post-pregnancy, I mean termination of it, we gave anti-VEGF and she started settling down with the symptoms. The macular edema came down. Though the blood vessels, you can see that it's much more altered, and the arterial attenuations can also be very well seen. So we have just discussed about what are the changes. I just want to repeat once again. So the conjunctival hemorrhage, as far as retina is concerned, we had exacerbation of diabetic retinopathy changes. We are talking about certain allied conditions where hypertension plays a role. One of them was the Elching spots, where there is a loss of choriocapillaries in the choroid, or hypertensive choroidopathy, malignant part of it. Second one is worsening of retinal vein occlusions. So let us take another case where there are certain combination of pathologies. Any of the patient is already pregnant, she is an hypertensive, along with certain systemic factors which cause the hypertension. For example, a connective tissue disorder or lupus. In such conditions, what would be the presentation? So this, again, a lady which presented to us with vision disturbance in both the eyes for about a week's time. She's a primary, again, with 2 previous miscarriage, and she has a strongly ANA positive. And the MRI that was done showed some small vessel pathology. We'll not go into dig into the details. It's beyond the preview of this. So, but on to the examination, we could see something like a frosted bench kind of a changes. So there is a vascular changes which was involving both the arteries and veins. She's a primary gravida, some amount of retinal hemorrhages, which was associated with the venous looping we could see. So we just asked them to go ahead with the rapid investigations to see whether she was anyway linked to lupus, and did she come out with positive. Just about 1 week later, you can see the right eye had a combined central retinal and central venous occlusions. As far as the left eye is concerned, she had a superior retinal vein and retinal artery occlusion. You can see very well the amount of retinal ischemia by the separation of the whitening of the retina in the superior temporal aspect as compared, which is just bordering up to the foveal aspect over there. So there's a combined occlusion in both the eyes, central in the right eye, and branch retinal vein and branch retinal artery occlusion in the left eye. So any patient who already has a connective tissue disorder, especially lupus, can precipitate very badly during their pregnancy, and that should be very much taken into account and followed up very carefully. So another case of collagen vascular disorder, which causes an accelerated progression. You can see in this patient, she's a 34-year-old multipara who had gestational diabetes with pregnancy-induced hypertension. Previous pregnancy, it was noted, and she had already undergone panretinal photocoagulation. And now she presents at the third trimester. So you can see the proliferation, and she's almost in the third trimester. So there's nothing much to do other than to just pray to the gods and wait for an ultimate outcome, a favorable outcome. But the amount of neovascularization is quite high in this patient. So just about a month later, when she presented again with a sudden drop of vision in the right eye, left eye is still holding good, and you can see the amount of exacerbated proliferation, which has gone, to cause a very nasty TRD, flat proliferation all over without any posterior vitreous detachment in this patient. So patient, we waited since it was again a precious pregnancy. So once the delivery was done, then we took up a surgery. And this is the post-operative image that I can be very where the entire proliferation has been removed and the retina is well attached with oil in situ. So not all the patient can end up with such favorable result. At the same time, patients with such nasty proliferation can also end up having better vision. That is what I just wanted to showcase in this. So any patient who is pregnant and who has a connective tissue disorder, we need to keep on following as far as the ocular condition is concerned, because they might just worsen like anything and downslip with a complete loss of vision. So the fallibility is very, very crucial in these patients to make sure that we don't miss out on such changes. Or if you want to ask the gynecology obstetrician to terminate the pregnancy a little bit advanced, once the fetus attains maturity, we don't want having issues with preterm babies also. At the same time, we don't want to lose the eye of the mother. So another common condition which can occur in pregnant ladies with PIH is NAI1. So very widely, most of these patients do have around 660 or better vision, and acquired loss of color, that is dyschromatopsia, typically is proportional to the vision acuity loss. This is very characteristic of NAI1 as compared to any other optic nerve pathology that we come across, like optic neuritis or any other thing where there's a complete loss of vision. We don't know how to collaborate the color vision as far as the NAI1 is the optic edema or pathology is concerned. But here, the vision loss and the dyschromatopsia is very typically go hand in hand. The pupils are usually round and symmetric, and there will be no anisocoria. And usually they do have RAPD provided the other eye is absolutely normal. So the common visual field loss that we can see in these patients is altitudinal field loss, inferior being the most common. So any of these patients who present to us with sudden onset loss of vision, one of the other differential diagnoses that we have to keep in mind is NAI1. We have to carefully look into these patients to see whether there is sectoral disc edema. And with altitudinal field defects, then we can ask, though self-recovery is in most of these patients do occur, we need to control their hypertension more aggressively so that the further attacks or the other eye can be totally prevented till the pregnancy is terminated. So looking into hypertensive retinopathy, let us just enumerate the Keith Wagner classification of hypertensive retinopathy. So we have 4 stages, where the first stage is just generalized arterial narrowing, the entire arteries in the fundus that we can appreciate. This grade 2 is where we have focal exudation, some amount of focal exudation and focal narrowing. Other than the generalized attenuation, there is a focal nipping or narrowing of the blood vessels. And third is where the exudation is numerous, where neurosensory some amount of collects in the fovea. And in the 4th grade, where is the worst of the hypertensive retinopathy stages, we have the established disc edema in bilateral, along with neurosensory detachment with art exudates that we can see in this patient. I had to borrow this image from the online bank because I couldn't recollect or take any of our patients who had grade 4 hypertensive retinopathy. Thankfully, because the various medical attention that they can easily avail and control of hypertension to a fair extent is readily possible in any of the corner of our country as of now. So we don't see these patients very commonly, but it's not that they never present to us. We have patients who present in conditions where the sugars are extraordinarily high, around 600s and so, and even in hypertension, malignant hypertensions, where a relatively young patient can present with disturbed vision, and when we see inside, we might end up seeing a grade 4 hypertensive retinopathy like in this. So most important is whenever we see a patient with disc edema, we always think in terms of whether it's a papilledema, especially if it's bilateral disc edema, we think in terms of papilledema. We need to differentiate 3 common, features of disc edema as far as pregnancy is concerned. One of the commonest that I just presented out is the bilateral disc edema, where the hypertension is the main cause. So it's preeclampsia, which has made sure that the disc goes into an hypoperfusion and edema. And there's a numerous amount of cottonwool spots, hard exudates at the macula, and central serous separation of the macula. So these are the features which very well demarcate the grade 4 hypertensive retinopathy in a pregnancy as compared to the other two conditions, which I'll enumerate out. What is the consequence of it? Why should we differentiate? Because yes, one though this has an ocular threatening feature, it doesn't cause. Usually, it is not associated with a life threatening, like how we have cerebral venous thrombosis patients. So, but what it essentially means to us, if a patient has a grade 4 hypertensive retinopathy with this amount of established disc edema and macular edema, then it's prudent on the obstetrician side to see to mature the fetus by giving steroids and others, and to terminate the pregnancy as early as possible, so that the vision can be preserved to whatever extent the patient is having, and make it much better than what she presents with. The other two causes of disc edema, bilateral disc edema, is common is cerebral venous thrombosis. It's life-threatening, so that needs to be treated along with the neuro team, and IAH, which is a little bit lesser, pathological compared to both of these conditions, but even that has to be handled, mostly associated with obesity, and that needs to be addressed too. See, other causes of central vision loss, which though we don't have any ocular features or symptoms, but the most important aspect, that's the vision, is lost in these cases. So we need to keep an account of this also. So this is the Sheehan syndrome. What I mean by Sheehan syndrome is there is an ischemic necrosis of the pituitary gland due to severe postpartum hemorrhage. There's a potential vision threatening issue because there is a sudden increase in the pituitary size, either because of there is an infarction or there's a bleed into the pituitary gland, increasing the size of the pituitary gland. So what are the symptoms typically the patient presents with is a sudden onset of headache, which was associated with either visual field defect, which is about 64% of these patients. This is typically a bitemporal superior quadrantic defect, or it can be a visual field loss, visual acuity loss, which is about 52%, which is because of the compression of the optic chiasma of the enlarging pituitary gland. Ophthalmoplegia, again, because of the compression of the optic nerves, the cranial nerve, sorry, which is present in 78% of these patients. The other cause of visual deterioration as far as PH is concerned is cortical blindness. What we define by cortical blindness is there should be a loss of vision without any local ophthalmological causes. So what I mean by how do we determine whether there is any local ophthalmological causes or not? So the patient should have a normal pupillary right reflexes. See, bilateral lesion in the striate cortex in the occipital lobe is where we expect the patient should have pathogenesis to have a cortical blindness. So whatever the pupillary reflex afferent pathways that occurs, usually it traverses just anterior to the lateral geniculate body. So whatever the lesion which occurs posterior to the lateral geniculate body shouldn't cause any kind of a pupillary disturbance. So there is a normal pupillary light reflexes which occur, and it is secondary to damage to visual pathway posterior to the lateral geniculate body. So commonest causes, there are innumerous causes which can be, stroke and other things in a normal, other individuals, in an adult other individuals. But as far as we are talking about pregnancy and PIH, so if there's a postpartum and perinatal ischemia, so both mother and the child can have this. So there might be a postpartum or a perinatal ischemia, which can be enlisted as the third most common cause of acquired cortical blindness. This is the reason behind is both the posterior cerebral artery and the middle cerebral artery both supply this specific area of the lateral geniculate and the posterior striae of the visual pathway. And if there's any such alteration in the blood vessel, in the blood supply to this, can cause infarct, and that can cause cortical blindness. A little bit more into dwelling, though it's not the purview of this, just to enumerate a little bit more. So there is something called as Oken nystagmus that we elicit. So it is a vertical striae of dark and white bands. And when we rotate it and ask the patient to see through it, so we can elicit two specific responses. One is symmetric Oken and asymmetric Oken. So if it is a symmetric Oken, then usually suggests an occipital lesion, which is the commonest cause of cortical blindness. And very few of the patients can have asymmetrical Oken, which is suggest a parietal lesion. What is symmetry and symmetrical is a neat pursuit of the rotating drum, and pursuit vision and then the refixation. So if the pursuit is neat, then it is called as symmetrical. If it's not, then it is called as asymmetrical. So there are certain other associated features, again, just to mention it out because they might ask as far as Viva or in theory, you might put it across. Three or four things which needs to be enumerated over here is the blind side. So there is the patient is having a total blind field, but he can see only some flicker movements, not a continuous movement as such. Only flicker movements can occur in these blind fields. It's called as blind sight in these patients. Another feature is the Anton syndrome, where the patient totally denies that he or she is blind. But when you ask to move individually, they cannot, and they confound this with confabulations. Redox phenomena is another thing where in these cortical blind areas, the patients might have a perception of dynamic, whatever the object is moving, though they can't identify the object, they can't tell about the object per se, but they can definitely perceive a dynamic object, but not a static object. So this is called as redox phenomena. More pertaining to our topic, why I enumerated all this, there is another thing called as the posterior reversible encephalopathy syndrome, which is an acute onset of headache, seizures, altered consciousness, and visual disturbance, which comes into the purview of cortical blindness. And it is commonly associated with malignant hypertension and eclampsia. Why it is called as reversible? Because once the hypertension is controlled, and all of these symptoms, even the MRI changes which can occur in the posterior aspect or the the occipital aspect of the brain is totally reversed and the changes becomes normalized. So that is why it is called as a posterior reversible encephalopathy syndrome. So coming to the cortical blindness part of it. So I've just enumerated about 10 or 11 conditions which we usually come across in a patient associated with pregnancy-induced hypertension in their ocular features. And looking into all of that, what I want to enumerate is in pregnancy, we have a myriad of ocular symptoms. If you look into the entire thing, that's why Sir gave me this limited topic, because if you look into the entire ocular changes in pregnancy, it'll be too vast to cover up in one particular an hour or whatever it is. More important, what I want to emphasize is a firm understanding of various ocular pathologies that might occur or get modified during pregnancy is very essential. And that will lead us to prompt evaluation and management, which cannot be better stressed other than whatever I've already shown, because most of these patients which have enumerated over there had some or a lot of visual deficit by the end of the pregnancy. Though it is an enjoyable thing for the woman, but it can lead on to such bad scars as far as vision is concerned. Thank you.
Thank you, Rajesh. Seriously, you pulled out so much of information. Frankly, you have made me wiser for sure about the hypertensive changes which happens in a pregnancy-induced hypertension. I'm sure the other discussant would also agree, or probably I am the only person who was so ignorant about this vast topic and wonderfully pulling out and helping us out in changing our way of looking at this particular disease. So, what do the other discussant feel? Are you wiser?
Yeah, actually, sir. Yeah. She has actually
it was
enumerated all the things.
Okay.
The case-wise discussion.
Seriously. So I think before we start the discussion, there are certain questions which the postgraduates have, they asked me on my mobile, the number which we have shared. I will just ask few of them. Any one of you can have the liberty to answer. The one question is that disc edema, sir, how do you differentiate between it? Is it because of hypertension, NAION, or diabetic papillary edema in a type of pregnancy setting? That's what probably he means. How do you differentiate different, whether it's hypertensive, diabetic? That's what I think he wants to know.
I think the commonest situations which can enumerate in a patient with pregnancy is, which I have already suggested over there, is one is PIH associated, that is the preeclampsia, where three most common factors that should be there, that is disc edema, which can be symmetrical or a little bit asymmetrical, along with disc hemorrhages. Most important is central serous detachment with there is edema, along with hard exudates. So these all changes should be present to call it as an hypertensive related, along with other changes, which is the Keith Wagner, which includes the arterial attenuation, narrowed nipping of the arteries, and RX rate. So all of this tells us that it's an hypertensive related, and the central serous detachment along the hard X rate says that there's a huge amount of water which is being collected, exudation which has been happening over there, as compared to the other causes of disc edema. Like if you look into the papilloedema part of it, you don't get the macular changes. It's only restricted to the disc, and we don't have the arterial changes which can happen. So these are the commonest which are there. And life-threatening situation which can cause an immediate change, like again the cavernous venous thrombosis can also present with the bilateral disc edema. Again, it's an acute onset. The arterial changes are not there. There is no changes at the macula aspect of it. So if at all you have all of these changes, which can be definitely associated with hypertensive related changes, then we need to put it as the grade 4 hypertensive retinopathy or preeclampsia associated, and that need to be treated separately as compared to the other conditions.
The next question is, I think I can ask Rahul to answer this.
Prashant, I'll just add one thing.
Please go ahead. Yeah.
So, like Dr. Rajesh answered the question very well, that, to differentiate a disc edema, the etiology, you have to look at the fundus and the disc edema both together. So that will give you an idea. The other thing is, if the patient's vision is good and you can elicit a visual fields or a perimetry, do a perimetry, that also will point to certain factors. Like if you have definitely altitudinal field loss, then you're looking at probably a ischemic neuropathy. If your diabetic papillopathy would probably give you more like secocentral defects. So visual field perimetry also will tell you the the etiology or how the disc edema is, to study it more effectively.
Okay. Anyone wants to answer?
Yeah.
For Rahul?
Yeah, so usually the ischemic optic neuropathy will present with the sectoral edema. It will not be usually it will start with a sectoral edema. And as rest of the point has been discussed, there has to be changes of hypertensive retinopathy because it's the stage 4 of hypertensive retinopathy. So there are all signs of stage 3, including the exudations, serous detachment, hard exudates, and retinal hemorrhages, along with the disc edema. So that is the stage 4. So all the signs of stage 3 hypertensive retinopathy are there.
One question the postgraduate asked, we are asked, should we terminate pregnancy in PIH? So when should we ask to terminate pregnancy in PIH? This is the question a postgraduate has asked. I think all of you can express your opinion. Why not start with Dr. Malay?
So actually, it's a very good question. I was just going through what the literature says. The legal safe limit of MTP is 20 weeks. And the 20 weeks, only after 20 weeks, you usually get preeclampsia, the PIH changes. So whenever we are talking of termination of pregnancy in a PIH case, a proper justification has to be there, and it will always be a trouble. Because there's an act, I think that is 1971 Act, which does not allow to terminate pregnancy beyond 20 weeks. So unless the situation is really grave, we would like to let the pregnancy go on, because after delivery, most of the changes are reversible. So unless the situation is really grave, even so much so that literature said that even if there is detachment, you should go ahead with the pregnancy, and the detachment actually subsides and the vision comes down. So this is what is my take.
Anyone else? Because his question is very true. Many times when we as a resident used to go, they would ask, should we terminate? So as a postgraduate, that question sounds to be, we need to tell them exact signs at which they can indicate termination of pregnancy or having an early seizure or whatever that is they have. So Preetham, Rajesh.
Yeah. So I'll put it in a different concept, in a perspective that why as ophthalmologists we play an important role is because the eye is the only place where you can actually see the blood vessels, right?
Yeah.
So the retinal vascular changes in PIH are going to tell the physician or the obstetrician about the vascular changes in the other end organs. The other end organs which are probably more important from the entire patient point of view, like say liver, the kidney status, the hemopoietic status, even for that matter, the placental vascular changes. So if our retinal vascular changes are able to, for them to see whether these other end organs are being challenged because of the eclampsia status, then it becomes a situation where a joint decision of termination of pregnancy becomes important. So at the end of the day, it will not be just one subspecialty taking a decision. It might be probably the obstetrician along with 2-3 other physicians taking a decision, because termination of pregnancy is a big decision from the for the family, for from the aspect of well-being of both the mother and the fetus. So it will be ultimately a joint decision which will have to be taken based on the affection of all the end organs.
So, if it could add up on a little bit, in the sense, nothing much. So, whatever cases that I enumerated, all were grave, and none of them were ready for any termination of pregnancy. That's the real fact as far as, I mean, you can say any country, but more so, let us limit to ourselves to Indian scenario, where all of us have a very, as far as mothers are concerned, they want to have a kid. And most of the families do want to have a kid, so they don't want to terminate at any cost, unless and until it's really vision threatening or a life threatening. So anything which can, we can push the pregnancy up to 32 weeks on a safe manner. The child can also be matured by giving more of steroids, and then the delivery can happen and surfactants can be pushed into the baby to make sure that that doesn't slip into other issues of preterm as well as ROP is concerned. So 32 weeks is what, and after that, if there's any systemic condition or ocular condition which mandates termination, it can be. Anything between 20 to 32 weeks is the crucial period that needs to be managed. I still remember we had a melanoma which was very much growing in size, and the vascularity had achieved another additional vascularity which could picked up on ultrasonography. So such a large tumor, but the mother was still denial of terminating of pregnancy because we wanted to do enucleation of the eye. She told whatever it is after the termination, I'll come back and you do the enucleation. So that's the state of attachment which mothers do have, and that's why we are all like this. So anything between 20 to 32 weeks is the most crucial part. We need to manage it somehow. After 32 weeks, it's just the obstetrician and the pediatrician should go hand in hand. And we can always, as Pritam sir has enumerated, that we can keep looking at the eye, see what is the changes that is occurring. And if we feel at any point of a time it's going to threaten the vision, then we can always ask them to, hasten the process and then terminate the pregnancy at the earlier date.
So I think, so residents, I think that message is clear that even if you are asked that early delivery, early seizure, can we take? It has to be, you should not reach out to a decision on your own. Always seek help of your senior consultants who are there in such extreme cases, because it has a lot of medico-legal implications. And most of the times, as I said, retinopathy, most of the changes are reversible. To some extent, it varies. The extent of reversibility of post-delivery can be varying, but that does not give you the freedom or the right to have an early seizure or early call. Please do not take it. Do take help of a senior faculty in your department. I think that message would be better for them, I think, for this question.
True, sir.
One more question is case 7, sir. Grade 4 hypertensive retinopathy. How do we differentiate between diabetic and hypertensive changes? Because everything exudates and everything looks similar. Anyone?
I can tell you, Prashant, when I was going through this pregnancy-induced hypertension, then I went through retinopathy of hypertension and diabetic retinopathy. We all interesting finding which I found in this whole picture was that hypertensive retinopathy more or less is surrounded near optic nerve, whereas diabetic retinopathy, you will find more features on the macula. So that's a disease of macula, and this is predominantly the findings are around this. The hemorrhages are on the disc, the arterial changes are there. And another thing is that sclerotic changes and the AV changes will be associated with predominantly hypertensive retinopathy. which will be lesser marked in that.
I think anyone more can add to this. Rahul, you are
Yeah.
muted.
And
Rahul, you're muted.
probably you could have both coexisting also together. You could be having a pregnant patient who could be in eclampsia and could be having diabetes also, and you could have a mixed picture of both retinopathies. So
Wants to know the difference. He says that there are exudates, hemorrhages, and everything similar in almost looking in case number 7. That is what you meant.
So
Case number.
actually, sir, am I audible, sir?
Yeah, Rahul.
Yeah.
So, sir, basically, the diabetes is to start with the microangiopathy. It initially starts at the arteriovenous crossing arteriovenous junctions and at the capillaries. It affects more there. Whereas hypertension is morely affecting the arterioles as per se. And as far as the hard exudates are concerned, their arrangement of the hard exudates can be a clue for them. It usually is the form of macular fan or macular star. It is arranged in that way in the hypertensive retinopathy more, whereas it is in a discrete manner or sometimes in a succinate manner in the diabetic retinopathy. So that way the arrangement of the hard exudates is also a clue.
One more question is, sir, steroids in hypertensive retinopathy, how does it help? And in which trimesters can we use steroids? And does it not increase the blood pressure further? These are 3 questions he has asked. So I think one of you can take, please. Why not with Rajesh first? So
Yes.
his questions are steroids in hypertensive, when do we use? Doesn't it increase blood pressure further? And in which trimester can we suggest, and which stages of hypertensive retinopathy? That's what he wants.
See, there is no role per se as such steroids. Steroids in a condition where there is an hypertension associated in pregnancy, we give steroids for the lung to mature in a fetus. So that's one of the commonest causes where we indicate steroids, that the obstetrician indicates, not us. If at all, as I suggested over there, the patient had an retinal vein occlusion in a younger aged patients who have retinal vein occlusion, we know that inflammatory CRVO or BRVO is more common as compared to the others. So steroids do help a lot in these patients. So pitching in both of that, because pregnant ladies are young, we can definitely give steroids in retinal vein occlusion or impending retinal vein occlusions to abort such a situation. And this steroid can help in both conditions, that is maturing the fetus if you want to terminate the pregnancy a bit earlier, as well as the condition per se in the eye, that is the retinal vein occlusion. Hypertensive retinopathy as such, if there's a huge amount of exudation, to decrease that exudation, you can give. That's almost in stage 3 to stage 4 of hypertensive retinopathy, where you are contemplating, because once the patient has a disc edema, pre-eclampsia is already set in, there is a 45 to 50% chances that the patient might slip into eclampsia. That is what is that kind of eclampsia is where the patient has seizures. So you need to prevent that. You can definitely give steroids, and the termination of pregnancy is very, very validated in such a situation. So steroid per se in hypertensive retinopathy is not indicated, is only in cases where there's a huge exudation and you want the fetus to, hasten the maturity of the fetus a little bit, as well as to decrease the exudation you give. Otherwise, the patient is having a retinal vein occlusion or an impending RVO, where it's because of the young age, we think inflammatory as a condition. That's why we indicate steroid in these patients. These are the only indication. Second, the question was that does that increase the hypertension? Yes, definitely. Steroids at any dosage does increase shoot up the hypertension. We need to counteract it with systemic hypertension, which is safe in pregnancy is concerned. So central sympatholytics, are the drug of choices in these patients. Anything associated with beta blockers or associated with AC inhibitors or angiotensin 2 inhibitors should be avoided in these patients. Central sympatholytics are the drug of choice in pregnancy, and they can definitely decrease the pressure. Only issue with this, these tablets doesn't act for longer. Orthostatic hypotension or postural hypertension is very, very common with these drugs. So all this to be taken care in a multidisciplinary approach. So yes, steroids is indicated and can be given in certain limited condition, and it has to be adequately counteracted with central sympatholytics.
And the one more question to it was, in which trimesters can we use all this steroids?
Okay. So
Okay.
usually steroids can be indicated in any of the trimester. There's no issue. So for example, if a patient has autoimmune problems like a weak age or any other uveitis per se, and the patient has to be controlled. If there's an acute exacerbation of any of these uveitic condition or autoimmune condition, we can give steroids in any of the trimester. It's pretty safe. There's no issues with it. If at all we are giving in terms of to enhance the maturity of the lung of the babies, as well as to make sure that there's a smooth pregnancy, to hasten the termination, we can better it is indicated in the third trimester. Only issue is like whether the child can end up having Cushingoid kind of syndromes because of the increased steroids. But there's a dose calculated, and there are steroid sparing agents also that can be used safely in pregnancy, that can be substituted along with a low dose steroids to keep things under control. That is for chronic issues such as your autoimmune problems, or you have uveitis where the patient wants to plan a family. We can safely shift to certain biologics and others which can be safely continued in pregnancy with a very low dose maintenance of steroids. So that can prevent the Cushingoid syndrome in the fetus as well.
One more point here is, Prashant. Hello.
Yes. Yes, Malay.
So we have to go into the basic etiopathology of PIH, and it has to do with the placental metabolism. And whenever there's PIH, there's a lot of prostaglandin release, and that is why the role of steroid also comes in. So this is the answer to the basic question, why steroids?
Rahul, any inputs from you over this steroids?
Yeah, sir. I mean, from ophthalmological point of view, whenever there is need for reducing the exudates, I would prefer more of giving the intravitreal steroids, which will not affect. But as far as the systemic steroids are concerned, except from the active vasculitis, that too with the under the supervision of the treating obstetrician, I would prefer not to start the steroids for any of these conditions. I'm talking about the systemic steroids. That is the jurisdiction of the treating obstetrician. As far as the ophthalmological concern, active vasculitis is one thing, but apart from that, intravitreal steroids are safer. I would probably go with those.
So I think it's a matter of debate now, with systemic versus local steroids in hypertensive associated with venous occlusion. Pritam, your say.
No, so I mean, it's pregnancy is not something like a diabetes or a hypertension. It's going to be forever. It's a transient. It's like a storm which is going to come and pass over. And Dr. Rajesh, very nicely he elucidated all the entire spectrum, and we realize that most of these conditions, most of these retinal vascular changes are self-limiting. As the event is going, the effect of the event is going to go by. So most of the time it is just masterly inactivity which is required from our sides to keep observing it. So any intervention, like for instance steroids, I think has to be reserved for vision threatening retinal vascular changes. If it's vision threatening, then we have to consider steroids. And like rightly said, these steroids have to be started with a very close conjunction with the physician, with the obstetrician, so that at no point in time, it is like a double-edged sword. You're treating the ophthalmic problem and you're creating other problems. That should not happen.
Most of the time when we are talking of steroids, actually the steroid has to be used by the obstetrician rather than an ophthalmologist.
Okay.
So to really put in perspective, the obstetrician doesn't look into this kind of problem at all. Neither, I mean, sorry to say that the amount of knowledge for that, as far as the eye is concerned, anything is very, very limited. So in conjunction with the rheumatologist would be the best person to start of any of these systemic immunomodulators or steroids. I'm not talking in perspective only of PIH. Even in other, we can have patients who are chronic uveitis patients who become pregnant. In some conditions, the antigen challenge is so minimized in pregnancy, they become totally normal. Like for example, in weak age patients, they become absolutely normal in the second and third trimester. And once the pregnancy terminates, they come back with a storm. So any of these conditions where you need systemic steroids as well as immunomodulators, better that you can take as far as eye, because most of the conditions can be limited only to the eye rather than the entire body, and the opticians don't really care about it. I think taking into a confidence a third specialty, that's the rheumatologist, is very, very prudent and crucial in these conditions to maintain the ocular integrity as much as possible.
Last question in this series they have asked is, sir, in one of your cases of collagen vascular disease with pregnancy induced hypertension, there were a lot of proliferations. Why not laser? Why should we wait for laser and anti-VEGFs? That's what his question is. I mean, probably he wants to know
Why not more laser or
in a pregnancy in that case, or given anti-VEGF till you did a surgery probably in that case last.
the first the patient was a multipara. The first primary she had undergone PRP already, and we could just finish up the pregnancy, the termination of pregnancy, and the proliferation increased during the second pregnancy. So that is what it really happened. So the first pregnancy, though she went into mixed retinopathy with the PDR changes, laser was done, and the vision was very much safeguarded during the first pregnancy, and she terminated the pregnancy well. When she came back for the second pregnancy, she ended up with us in the third trimester. She didn't come in the first or second, and in the third trimester, the proliferation had regrown again, and within a matter of 1 month, it just proliferated like anything. So I don't know what in between. We repeatedly asked her whether, because she was already known a collagen vascular disease, so she was already on these drugs, and in consultorium with the rheumatologist, I think there was some lack, because she presented to us in the third trimester very well knowing that she had ocular problems. We had already enumerated that the ocular condition is basically related to the pregnancy per se. She came to us in the third trimester. So there is some lack of, medical negligence that had happened during, not medical negligence, that's not the right word, that she didn't go for a medical opinion in the onset of the second pregnancy itself. So the second pregnancy, when she presented to us, the management was still going on in the third trimester. But despite all of that, in the right eye, she progressed very worse. The left eye was still holding upon with a flat polyp without much of TRD. Now, since the TID progressed very bad, the vision dropped. That's why we took up for surgery. Otherwise, yes, lasers would be the first go, and that was very well done in the first pregnancy itself.
So postgraduates, probably the message is laser was not contraindicated. Only patient was a bit reluctant and she was postponing, and so surgery. Eventually she wanted some intervention only after the delivery of a baby.
Yes. Yes.
But yes, anti-VEGF. The question was anti-VEGF. Could we have used it? Anti-VEGFs is a big no in a pregnancy, as Dr. Rajesh has already said that the anti-VEGF is classified into which group of drug for pregnancy?
D or X. D or X. Still, there is some confusion. Some put it as D, where there is known risk factors.
Can we clarify on D and X for the sake of postgraduates? Just
so we can put it as D.
So what does it mean for them?
It means to say there is a risk, definitive risk involved in using anti-VEGF in pregnant patients to the fetuses.
Okay, fine. So it means anti-VEGFs is out of the purview of treatment for any form of retinopathy in a case of whenever a baby, when a lady is pregnant.
Yes.
Correct. That is what we want you to carry forward. Only thing is probably steroids, which we had some discussion, Dr. Rahul has initiated. Probably that is a safe, can be a safe option in certain limited cases, not in every case. That is what you should be very clear about it. So I think I have exhausted the questions which the postgraduate had asked us. So now we can further continue the discussion. Some Malay, you can add upon whatever is left over you feel can be beneficial to the postgraduates.
From the postgraduate point of view, the only one point I thought was worth mentioning. Rest everything has been actually presented from the clinician's point of view in a very high level. That was about the classification of the hypertensive retinopathy as far as pregnancy-induced hypertension is concerned. And I could come across 3 names. One was She's classification. Then there was a Keith Wagner-Buck classification. There's a Wong Michel classification of 2004. And now there is a classification based on OCT, which says that OCT-based classification says that there are mild changes without SRF, and mild changes with SRF. So this point may be of interest for postgraduates. Two features, two signs which are often asked are Gunn sign and Salus sign, which are actually signs of arteriosclerotic changes, where proximal part gets dilated and the vein becomes like a gun, therefore Gunn sign. And the Salus sign is the sign where instead of arteriovenous junction remaining a less than 90 degrees angle becomes more than, so that becomes obtuse angle. So these were the points which I thought was worth mentioning from the postgraduate.
Dr. Rahul, you can add upon for the sake of postgraduates to feel some more information.
Yeah, as sir has mentioned about the signs, I think I remember bonnet sign was another one sign, which is like gun sign only, but it is basically the banking of retinal veins distal to the AV crossings. So that is, and the copper wiring and the silver wiring of the these are two things. So they usually the light reflex of the arterial light reflex. So as it gets more and more wider, we call it copper wiring and then silver wiring. So they again shows the more severity of the hypertensive changes in the retina.
I think all these signs
Yeah, I think
will
the
be visible with direct ophthalmoscope,
bonnets.
or will it be visible by indirect ophthalmoscopy? Just for the sake of postgraduates, I want them to understand. So one of you, Pritam, would it be visible with the indirect?
Before that, the bonnet sign, I think Duke Elders, I think, has described it properly. Bonnet sign is called as a pre-thrombotic sign, where along with the banking of the blood vessel and deflection of the blood vessel, you're supposed to look for a retinal hemorrhage and soft exudates in the vicinity of the arteriovenous crossing. So that was, I think, the Bonnet's pre-thrombotic sign. And these most of
You are muted. Pritam, you got muted.
Can you hear me now?
Better. Yes.
Yeah. So, with I think the best way would be to do with a direct ophthalmoscope, because you get larger magnification, but and to look at a AV crossing and look for Gunn's and Salus's sign with an indirect ophthalmoscope will be difficult. Rather than an indirect ophthalmoscope, probably a 90D biomicroscopy would give you a better view of all these changes, because the most commonest changes in PIH would be the arteriolar attenuation.
You're muted again, Pritam.
The most commonest signs in PIH would be the arteriolar attenuation and the AV crossing changes. So I would suggest a slit lamp biomicroscopy would be better to elicit all these signs.
Great. Anything more, Pritam, from your side for the postgraduates in this particular topic?
I rest my case.
Okay.
Sir, one point I would like to add, sir.
Please go ahead.
As we talk about the hypertensive retinopathy changes and changes in the PIH, I think the basic difference is the PIH is something which is there was no hypertension before the pregnancy. It was of the acute onset. So acute onset vasospasm leads to typically more of choroidal signs like Elschnig spots and Segres signs, which usually happens in either the malignant hypertension when there is no pregnancy, or eclampsia and preeclampsia. And more of the retinal changes, they happen over the chronic changes. So they are more commonly seen in hypertensive retinopathy, but more of choroidal changes typically in the PIH and eclampsia when we are talking about. So that is one point.
Yes, so very well brought out, Rahul. So postgraduates, what he meant is that we need to understand that as we age, there is a changes in the vascular constitution. Your muscular tissues in the vessels are replaced by fibrotic. So that is what is called sclerosis, which is in itself a defense mechanisms. while in a younger patients, they are more vascular, the vascular tree is not that sclerosed. And so there are more acute changes which are not guarded. So you will see more of a spasms, more of a exudation because of a great rise of a sudden rise of pressures and all. And superimposed changes chronic are seen in a hypertensive retinopathy. Did I explain it properly, or can you just make it simple for the postgraduates?
More or less, I think the point which you said is absolutely correct.
So this is the way I think. So I think we had enough discussion. Anything I think, Rajesh, anything you would like to conclude with?
Conclude this. Thank you, sir.
No.
Yeah, that is what we used to say.
I
For that
think
opportunity
no,
that
no.
Thank
It
you,
is not,
sir.
we are not here to thank each other and pat each other. We are all here for the postgraduates, our future generation who are going to be our future of our country. So Rajesh, seriously, I mean it. You pulled out really well the literature. Many of the things which you have told today, shared with us, have definitely made me wiser as well, in spite of being a retina surgeon for so long and I've been practicing. Somehow, over a period of time, as we become mature retina surgeon, we move from direct ophthalmoscope to indirect. Many of the smaller signs we have tend to overlook, I believe, in the early stages of hypertensive retinopathy or in a pregnancy induced hypertension as well. So I think we will be more careful when we look at the patient, such patients. We'll try to use a 90D or a 78 diopter or a slit lamp biomicroscopy, as well as direct ophthalmoscope, which has seriously direct ophthalmoscope had means absent from our OPD, which we should go back to, I believe, for at least these changes. And also the systemic associations, which you brought out so well. I'm really thankful for doing such a great job for all the postgraduates. On behalf of them, I should thank you all. And of course,
Prashant, I hope this is recorded, because
yeah.
I'm going to go back and tell all my PGs who missed this to see it.
Yes. This will be always on our AIOS site. They can archive it anytime. And most of the times, YouTube and Facebook, they will be able to archive. And trust me, on an average, the viewership is 1,500 to 4,000 on interesting topics, what they feel interesting, especially the clinical cases or off-bit topics like this. So thank you once more, Dr. Malay, Dr. Rahul, and
Thank
Dr.
you,
Thank you, sir.
Dr.
Thank you, sir.
For
Prashant.
sparing your valuable time, and of course, Rajesh, for doing a fantastic job for and doing justice to this topic. So,
Thank you.
I'll just put one point, sir. We had a long question in our DNB exam on this particular topic, the pregnancy-induced hypertension. Now, I think I should have been a PG, or you should have been a chairman ARC, so that I should have seen this topic before. I would have written it much better than what I did.
That's what I said. After 25 years of practice, we learned so much from Rajesh talk that it is so comprehensive, and so means so many things can be written and spoken about it, which we definitely used to overlook probably for want of knowledge or for want of understanding. Thank you, That's why I thanked
Thank you,
Rajesh
sir.
very profusely the moment he finished, for making me wiser as well. So
Thanks all the members, and thanks Prashant.
thank you,
Thank you, sir.
everyone.
Thank
So
you,
Thank you,
Prashant.
everyone.
yeah, we will be meeting again on the following coming Thursday at 8 p.m. That time we'll be having a journal club. Till then, it's time for us to say bye-bye. And thank you once more, every one of you. Thank you.
Thank you, sir.
Rajesh,
Thank you.
from the bottom
Thank you,
of
sir.
Take care.